Okay, so what we're gonna go over now is the medical scenario or the medical skill sheet rather. And I will essentially go over a scenario and go through the skill sheet. And this will be expected of you when we do our next session after we do the splitting of your patients, and then we'll dive into medical and trauma. And so as much as I would like you to go through it verbatim and in order, we recognize that you might forget something and then come back, and that's perfectly acceptable. But nonetheless, I want to demonstrate for you how we're going to do it, and so you have a good idea. So the scenario that for this one is a chest pain patient. Much like I went over with you on day one, I'm going to go through the skill sheet, and so you can kind of see it in action. So you're dispatched to a chest pain patient. Let's say it's a 75-year-old male. He's at a residence, and he's having chest pain and some difficulty breathing. So the first thing you're going to do when you get onto the scene is take or verbalize appropriate PPE precautions. So you're going to be wearing most likely an N95 mask, gloves, eye protection, maybe a gown, depending on the situation. And also recognize that you're going into wildland. You may incur, a 50-year-old male with chest pain. You're not going to have all that PPE with you right away, but nonetheless, it wouldn't hurt to have a N95 mask in your pack. So we're going to determine the scene is safe. You arrive on scene. The wife's on the front porch saying, "Hey, this is where we're at. It appears safe at this point." You walk into the scene, see him sitting in a chair holding his chest. So determining the mechanism of injury or nature of illness. This at this point appears to be a chest pain nature of illness, cardiac in nature. We're going to determine, is this the only patient? We're going to ask maybe the wife, "Are you feeling okay too?" "Yeah, I feel fine." Maybe to rule out a carbon monoxide call, or maybe that they're experiencing some other medical emergency. So at this point, we're going to request additional EMS as necessary. So if you don't already have a paramedic en route, you're going to ask for them. You might have a paramedic with you. And then we're going to consider stabilization of the spine. And at this point, we're just going to consider it. We're not going to place them in cervical spine precautions unless during our assessment it dictates that maybe they fell, they're having that neck pain, and we need to put them in C-spine, put them in a C-collar. So as we walk in during the primary survey, we're going to verbalize the general impression of the patient. So as we walk in, we're going to look at the patient. They look really cruddy, holding their chest kind of bent over a little bit. We kind of look at this as a good, fair, or poor. We're going to say that he's in a poor to fair as our impression. Determine responsiveness, level of consciousness. So we're going to talk to him. "Hey, sir, how you doing? My name's Adam. I'm an EMT with the fire department." "Oh, how you doing? I'm having a lot of chest pain." So he just told you his chief complaint, and we're going to also determine any other apparent life threats, such as any bleeding or anything else. Maybe he's choking. Maybe there's something sticking out of his chest. At this point, there's not. So going back to the level of responsiveness, AVPU, if he's alert, verbal, alert to painful stimuli, or if he's totally unresponsive. Okay, now it's time to assess his airway and breathing. We're going to assess it. We're going to see if he's having adequate ventilation, maybe by watching his chest rise and fall. You could, at this point, try to determine the number of respirations, and then also initiate appropriate oxygen therapy. Like I told you earlier, the book talks about only initiating oxygen at 94% or above. 94% or below for oxygen saturation. But if it's appropriate for the call, you're going to initiate that. Then we're going to assess the circulation. Is this person have any major bleeding? He's only complaining of any cardiac complications. I don't see any other major bleeding. We're going to check that pulse. Most likely it's going to be that radial pulse. Is it present and is it equal? We're going to assess the skin, color, temperature, condition. On someone having a cardiac event, I may see some diaphoresis, pale, coolness of the skin. And at this point, we're going to identify the patient's priority and transport them as appropriate. So I'm going to say we're going to transport this person. He's having a cardiac event and they need transported. At this point, I would also take a quick set of vital signs before we move into that transport. So initially, his vital signs are he has a blood pressure of 142/70. He's got respirations of 20 and slightly labored breathing. His oxygen saturations are 92%. So we are going to initiate high flow oxygen via non-rebreather. And he's got a pulse of 88 and irregular. So when we go down to the history taking, we're going to look at the history of present illness. So this is where our OPQRST comes in. We're going to, talk to him. Hey, what's your name first? Yeah, my name's Frank. What happened when your chest pain started? Let's just say he was out working in the garage and he's been having this chest pain for about an hour before he decided to call. So, go through provocation. Does anything make it worse? And he's going to tell you yes or no. It might be movement. You might have him take a deep breath. If that goes away or comes back, you're going to want to document it as such. But you're trying to determine whether this is a cardiac chest pain versus a musculoskeletal chest pain. And then you're going to go to quality. What type of pain is that? What's the quality of it? Is it dull, pulsating? Is it a stabbing type pain? The new radiation, does that pain radiate anywhere? Yes, it radiates into my left arm or it radiates to my jaw. It might be both. It might be numbness and tingling in one extremity or the other. And then severity. This is where we trend to see if our interventions later will work. So initially, he's having 9 out of 10 pain. So we quantify it, on a scale of 1 to 10, 10 being the worst pain I've ever had. What would you rate that pain? It's a 9 out of 10. Okay, that is our anchor point. That is what it is when we're at right now. And then time. I told you earlier, just a minute ago, that it was his pain has been going on for about an hour. And so then clarifying questions, associated signs and symptoms with OPQRST. You might, do a quick inspection of his chest, might feel it. Then you're going to go into a sample history. So your signs and symptoms are already pale, cool, diaphoresis, slight difficulty breathing, heaviness in the chest, numbness in the left arm. Sir, do you have any allergies? No allergies at all. Do you have any past pertinent history? I had a triple bypass about 10 years ago. I've got high cholesterol, high blood pressure, and I had a knee surgery about 2 years ago. Okay. So I skipped over medication. So, sir, are you on any medications? Yes, I take metoprolol, Crestor. I am prescribed nitroglycerin. I take 1 daily aspirin, and then I take some miscellaneous vitamins. Okay, we can work with that. When's the last time you had something to eat? I just had lunch about 3 hours ago, and it was just a sandwich and a glass of milk. Okay, what were the events leading up to it? You already determined that he was out in the garage. He's had it for about an hour. So with the secondary assessment, you're going to assess the affected body part or system. We're going to determine that this is cardiovascular. So you might get lung sounds, like I mentioned a little bit ago. You might palpate the area, look for tenderness, any trauma that might be associated with it. So we already got that initial set of vital signs. This is after the secondary assessment. It states it again. So this would be appropriate as well. So you state the field impression of the patient. So I believe that this person is having cardiac chest pain. He is prescribed nitroglycerin, which you can assist with. I also going to be giving this patient 324 milligrams of aspirin, as long as they're not allergic to it. And I'm going to verify whether that patient took his aspirin for the day. And he's going to tell you, no, he takes it at night before he goes to bed. So he's eligible for all 4 baby aspirin, which are 81 milligrams, and for a total of 324 milligrams. So you also need to verbalize that your contraindications for the nitroglycerin. So I'm going to go through my 5 rights, right? Patient, time, dose, prescription, and the route and documentation. And then I'm going to ask him if he's taken any ED medication, erectile dysfunction medication. And I'm also have determined that his systolic blood pressure is above 100, so he's eligible to take that. So I'm going to look at it. It's within date. I'm going to give 1 pill to him and have him put that pill underneath his tongue, which is 0.4 milligrams. Might let him know that it might burn a little bit, might give him a slight headache. But after 5 minutes, we're going to reassess the patient's condition and determine whether that chest pain's gotten any better. So I'll take another set of vitals. You're going to take a set of vitals every 5 minutes because they're a more critical patient. And then you're going to, if that blood pressure comes back, let's say the blood pressure comes back at 132/76. So the systolic pressure lowered just a little bit. I'm going to give him another nitroglycerin. I forgot about severity. So the severity of his pain has dropped to 6/10. So that is getting better. So give that second nitro, 5 minutes later, take another blood pressure. His blood pressure is now 120/68. His severity of his pain has dropped to a 4. We want this person to be as pain-free as possible if we can get there. So I'm going to give him 1 last nitro and check his vitals. 5 minutes later, his blood pressure is 116/66. So his blood pressure is still good. And his condition's getting better. He's becoming more pain-free. With the nitroglycerin, if there's any question on whether you can give that nitro or not, you can always consult with medical direction. And then lastly, you're going to provide an accurate verbal report to the arriving EMS unit, or if you've already transported, maybe to the hospital staff. So your patient transfer might sound something like this. Hello, this is Frank. We were dispatched for a sudden chest pain. We arrived on scene, determined this is a 75-year-old male experiencing acute chest pain, initially 9/10. We've given a total of 3 nitro. His pain is now 0 to 1. The most current set of vitals is a blood pressure of 116/66. Pulse is that, blood pressure is that, respirations or whatever they are. Currently resting comfortably. He's got a history of this. He takes these medications, and of course, everything you've done for him, including the aspirin, and essentially the scenario is over. So. Any questions? Okay, in this scenario, we're going to cover the trauma skill sheet, and I'll give you a scenario of a 30-year-old male that has fallen from the 2nd story of a roof. So as in much like the medical skill sheet, we're going to take or verbalize appropriate PPE precautions with the gloves, eye protection, possibly a gown, and an N95 mask. We're going to determine the scene is safe. So the scene that you're being dispatched to is a construction site where multiple new apartment buildings are being built. The dispatch information states that a 30-year-old male lost his balance and fell on the gravel and uneven ground below. So at this point, the scene is safe. You arrive and see a group of individuals standing around this male lying on the ground. We're going to determine the mechanism of injury. which is the fall. Determine a number of patients. So foreman comes up to you and says, Joey just fell off the roof. You got to help him. You got to help him. You ask him, has anybody else get hurt? Did he fall on anybody? No, it's just Joey. He fell down. You got to help him. Okay. So due to the mechanism of injury, you're going to request additional EMS if necessary, which could include a helicopter. It could be law enforcement for traffic control. It could be another ambulance for additional assistance. So we're going to consider C-spine stabilization of the spine. Due to the mechanism, we're going to initially take C-spine. At this point, it's you and your partner on the scene, and there's another individual there that identifies himself as an EMT who is already holding C-spine. So you're going to let them continue to do that. So I'm going to verbalize the general impression of the patient, good, fair, poor. I have a 30-year-old male lying on the ground, supine. At this point, he's not looking at me, but appears to be breathing. His eyes are closed. So I'm going to say my general impression is poor. So I'm going to determine the level of responsiveness. So I'm going to talk to him. Hey, Joey, can you hear me? No response. Hey, Joey, can you hear me? Nothing. So you reach up and you pinch his trapezius, his shoulder, and he wakes up and mumbles some words. Hey, what happened? What's going on? So he's currently alert to painful stimuli. You talk to him. Hey, Joey, what's wrong? What's hurting? So you determine his chief complaint or other apparent life threats. You do a quick scan of the patient. You do not see any penetrations, any screwdrivers or rebar sticking into him. And at this point, you don't see any uncontrolled bleeding. You do see what appear to be some maybe a broken ankle and a broken arm, but they're not life-threatening. So I'm going to assess the airway. So I'm going to open it and assess it. He is breathing. I do see chest rise and fall. And I'm going to insert an adjunct as indicated, and it's not indicated for this person yet. There's a little bit of blood around his lips, but it's not significant. The breathing, I'm going to assess the breathing. He is breathing shallow at 12 to 14 a minute. That's where I'm going to assure the adequate ventilation as well. At this point, because of his low breathing rate, I'm going to initiate high flow oxygen, and I'm going to manage any injury which may compromise the ventilation and breathing. As I said, there's some blood around his lips. So I'm going to look in his airway, and what I do see is a little bit of blood in the back of his airway and a couple of broken teeth. So at this point, I'm going to suction the airway and ensure he doesn't aspirate any fluids. With his circulation, I'm going to check his pulse. He does have a radial pulse. It's fairly weak, but it is there. I'm going to assess the skin, color, temperature, condition. His skin is cool, dry, and pink. It is cool because of the outside conditions. Let's say that it's 30 degrees on an early spring day, and he was just wearing a t-shirt. You're going to control major bleeding if present. At this point, I said that he doesn't have any major bleeding, and I'm going to initiate shock management. So I'm going to place him in a supine position, maybe a Trendelenburg position, and cover him with a blanket to keep him warm. He's going to be a priority transport, so we're going to get him in the back of the ambulance and transport immediately. So at this point, when we're in the back of the ambulance, we're going to take a quick baseline vital signs. He's got a blood pressure of 110 over 70. His heart rate is 98. His respirations are 14 and slightly labored. His oxygen saturations on the oxygen are 99%. And his temperature is 98.2. So at this point, we're going to obtain a sample history. So we're going to ask Joey, wake him up a little bit, or if there's anybody else that has any other information around him, determine whether he has any allergies, medications, past pertinent history, last oral intake, and try to figure out what the events leading up to the incident were. So signs and symptoms are altered level of consciousness with an obvious fracture of a foot or leg and an arm or a wrist. He says he has no allergies. For medications, he takes Seroquel. For past pertinent history, he discusses having some mental issues over the last 10 years. His last oral intake was lunch, and events leading up to it was that he stated he started feeling dizzy and lost his balance on the roof and fell off. So as we do our secondary assessment, we're going to, in fact, before we go there, since he is altered, we're going to check his blood sugar to determine whether or not it's hypoglycemia as part of that. And we get a blood sugar back of 88, which is within normal limits. So we're going to rule hypoglycemia out. On our secondary assessment, we're going to start at the head. We're going to inspect, palpate the scalp and ears. We're going to look at our gloves to see if there's any glove on it or any blood on it. At this point, he does have a contusion on the posterior side of the head with a controlled minor bleeding. We're also, as we inspect during this secondary assessment, we're going to look for decap BTLS, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. So we've inspected the palp. Now we're going to look at the eyes. Are the eyes pearl, which are equal and reactive to light, which they are. We're going to inspect the mouth and nose and facial area. We're going to palpate it. We're going to look at it. We've addressed the blood and broken teeth in the mouth by suctioning them. We only notice a little bit of dirt on his face. We're going to check his neck. We're going to look at the position of the trachea, make sure it's in line, check for any jugular vein distension. We're going to palpate that cervical spine for any crepitus, any step off, any painful with it. As we inspect that, we can move on to the chest. We're going to check the clavicles, make sure they're intact, which they are. We're going to check the chest. We're going to push straight down. We're going to push on the sides. We can also auscultate for lung sounds to make sure they're clear and equal bilaterally, which they are. What you do notice is that there's a slight tenderness on the left side of the chest. So it's on the side that he fell on. You inspect that. You're going to cut off his shirt in the back of the ambulance. What you notice is a small area, about 2 by 3 inches in size, where it's tender, it's bruised, and there's some crepitus involved. We're going to move down to the abdomen. We're going to palpate all 4 quadrants by using our hands nice and slow. We're going to feel for any rigidity, tenderness. At this point, you do feel a little bit of rigidity on the left upper quadrant. You inspect that. It's slightly discolored, but it certainly is tender. We're going to note that and move on. We're going to assess the pelvis by pushing straight down and in. It's tender, but it appears to be intact. There's no crepitus. And we're going to move on to the verbalizing, assessing the genitalia or perineum as needed. So we're going to now move to the lower extremities. We're going to palpate the thighs. We're going to assure that there's no excessive movement and that the femurs are intact, which they are on both extremities. You move down to the lower left foot, and the left ankle is slightly angulated and severely swollen and painful. You check CMS on that, so he's able to move his toes, he's able to feel it, and you do feel a distal pulse on the dorsalis pedis, and you're going to mark that with a pen. You move down the other extremity. lower leg, all that is intact. CMS is good. And then inspect the upper extremities with the arms. There is a broken left arm, and it is, again, slightly angulated. These are not life-threatening injuries, so we're going to determine them as secondary injuries and splint them after our secondary assessment is done. So CMS is good on both arms. We're going to verbalize that we would have inspected the lumbar and the thorax and the buttocks on the posterior side of the patient. At this point, we're just seeing some bruises and some small lacerations from the fall. So now we're going to manage those secondary injuries and wounds as appropriate. Might put a bandage over some of the lacerations, and then we're going to splint the arm and the leg or the foot. So this patient to me is on the more critical side. So we're going to reassess his vital signs every 5 minutes, monitor his airway, monitor his level of consciousness, and then continue transport to the hospital.